We're back. I think we got 2 or 3 more lectures coming up for this year. Let me have a quick look. We got Amir. No, 1 more. Yeah, which makes sense. And because Australia closes for about 6 weeks.
It really does, yeah. January, nothing happens.
I love it. I love it. It is so unnatural, but I still love it. It's like, you're not worried because now it's just closed. No, you can't have it.
Recording in progress.
All right. Welcome everybody back to another webinar, Sydney Neonatal webinar. And today we're going to talk about ethics. And I've invited Amir Zayegh to come talk to us. Amir is a neonatologist from Melbourne, but he's also trained in Oxford, where he did his master's in practical ethics, and he's now doing his PhD in research ethics. And last time I heard Amir talk, and we talked about there's always like in smaller countries, there's one person who has to take over sort of the lead if the previous sort of grand ethicus sort of left. And I think, Amir, I generally have my sticks up to you because I really enjoyed this talk you gave, and I hope you will enjoy this too. So Amir, over to you.
Thanks very much, Kurt, for the very kind introduction. I'll get straight into things then, and hoping that I haven't made the presentation too long to allow for plenty of discussion and amongst ourselves, because the idea is really to provoke some reflection and discussion. So today I'll be talking about how difficult decisions being made in the beginning and end of life for infants in Victoria. And I say Victoria, but actually I'm going to focus on my hospital context. So firstly, I'm going to briefly touch on the Australian healthcare legal and ethical context, which affects decision-making in NICU, very briefly. But the goal of the talk is really to present a reflection on how ethical decisions are playing out in a large tertiary maternity hospital in Victoria and how they might be justified. And the idea is to encourage reflection on practices in your own hospital. And I'll use 2 different situations or case studies. The first is around what we do with threatened preterm birth at 22 to 23 weeks. And the second is a brief look at withholding or withdrawing intensive care for infants with brain injury or infants with life-limiting conditions. So I always love to start with this slide, regardless of the talk. I find it really fascinating, and it's a reminder that we live in a really, really large isolated country, a continent really, and that does have an impact on how we provide, particularly neonatal care. There are certainly a number of geographical, political, and social factors which affect how we practice and make decisions in NICU. So it's useful to think about them briefly. The first, by necessity, as you know, there's a centralisation of care and a busy neonatal transport service around Australia, really. We also have publicly funded tertiary NICUs, so cost is not something that plays generally into ethical decision making for us or our NICU parents. Like it does in most other places around the world, although in a small number of cases it can become very, very relevant. Thirdly, Australia's major cities, as you know, are very culturally diverse, and at least 50% of people have one parent born overseas. That was in the last census. That brings with it moral and religious diversity. And when you combine that with a strong focus on autonomy in our healthcare settings, it leads to having a wider zone of parental discretion. So compare that with somewhere like Japan, where they provide resus to 22-weekers since the 1990s, and there's a much narrower zone of parental discretion. However, despite our diversity, we still live in an individualistic culture compared with more collectivist cultures in many other places around the world. And we also have liberal or permissive abortion laws. And when you combine those, they contribute to a strong focus on autonomy, but also a trend towards disability aversion or avoidance, particularly in healthcare workers and health policy. And this colours how treatment options are presented or framed to parents. Hospital and professional guidelines in Australia advise shared decision-making, in particular for difficult decisions where prognosis is uncertain, and we often call it the grey zone. As you know, shared decision-making ideally involves exploring parental values, goals, and preferences, and then helping them to make the decision that best aligns with those values. The limits to that are, in theory, bounded by best interests on one end, where something is clearly beneficial for the child and therefore the parent should not be able to refuse it. And on the other hand, the harm threshold. So at some point, there is something that will be so harmful for the child that, again, parents should not be able to request it. However, in reality, the discussions that we have with parents can tend towards either non-directive counselling, where parents are simply provided with information without any recommendations, or paternalism on the other end, where there are strong recommendations from clinicians about what the parents should do. And it is a spectrum where we will all fluctuate between this. With more paternalistic counselling, there is the potential that some parents feel pressured into, for example, withdrawal or withholding decisions when there are recommendations to do so. But on the other hand, non-directive counselling places all of the burden of decision-making on the parents. And many parents tell us that they don't want this, and they prefer that their clinicians help them by making a recommendation. I really like this graphic from Dominic Wilkinson, one of his papers. It shows a visual sense of how we try and decide about thresholds for treatment. There are treatments that are definitely beneficial. So offering intensive care for a 25 or 26 weeker, we know most of them will do well. There are also treatments that are definitely harmful. So at the moment, offering intensive care less than 22 weeks gestation would fit there. As we know that we'll do lots of painful and uncomfortable interventions, and almost all of them will die despite that. So in the grey zone, where the probability of success of intensive care is more uncertain, then we give more weight to parental values and wishes. So in this grey zone, there is a benefit of time when prognosis is uncertain or when parental wishes are uncertain. And so if one of those two things is happening and we are waiting to get more clarity, then it's also important to think about adequate relief of suffering. There's also the principle of justice or fairness. And in this situation, it's around consistency of decision making. So we know that there are value judgments involved in making decisions about whether something is or is not in the grey zone. However, because it does involve value judgments, it's important to try and be consistent. And things like having guidelines and team-based decisions for things in the grey zone becomes really important. So moving to the first situation or case study to help frame some of the difficult decisions that we make, I'll focus on antenatal counselling and threatened preterm birth. So here are some examples of cases that we've seen in our hospital. The first is a 35-year-old woman with threatened preterm labour and ruptured membranes who presents at 22 plus 4 weeks gestation. There's no additional risk factors for the fetus, who is well grown, has no major anomalies, and the mother doesn't have chorio. The parents, after the discussion, request for everything to be done for active care. They were advised during the counselling that intensive care is not recommended in the 22nd week of gestation, but would be supported from 48 hours after the first dose of antenatal steroids, so from 22 plus 6. However, the mother then developed chorioamnionitis within 12 hours and was induced the next day to protect her, and the baby did not receive resuscitation. Another case was of a 25-year-old woman who was transferred from a peripheral hospital at 23 plus 1 weeks gestation with rapidly evolving preeclampsia, and she soon developed an eclamptic fit after arrival, was intubated and taken for an emergency cesarean section. And that baby was born and received intensive care despite no time for antenatal steroids or magnesium sulfate. So that's kind of setting the scene for a bit of a discussion about the Safer Care Victoria Extreme Prematurity Guideline, which came out in 2020, and how that's changed our practice in Victoria, and particularly in our hospital, which I can speak to. So a team of experts came together within Victoria and developed this guideline in late 2020, and it's publicly available for you to search and find. And it was based on increasing evidence, as you know, around the world, that outcomes for 22-weekers were not universally poor. The main changes in this guideline were that the threshold for resuscitation was lowered from 23 to 22 weeks gestation, and the zone of parental discretion was used explicitly as a concept to guide decision-making. So between 22 and 22 plus 6 weeks, palliative care is recommended given the current statistics about outcomes at those gestations, if intensive care was to be provided. However, active care would be supported and provided from 48 hours after maternal administration of corticosteroids if parents wanted active care following counselling. So if they arrived and the mother went into labour without steroids on board and without counselling, then the infant would not be provided with intensive care. However, in the 23rd week of gestation, intensive care is recommended even without antenatal steroids, unless parents requested palliative care following counselling. So the opposite, really. Palliative care is then not routinely offered from 24 weeks onwards unless there are adverse risk factors or fetal anomalies. So importantly, this guideline acknowledges that there are other risk factors other than gestation, such as growth restriction, being born outside of a tertiary hospital, as you can see there, some of the others, that are just as important as gestation and can affect whether a specific case falls within the zone of parental discretion or not. So, for example, a very growth restricted 22-weeker would not be offered intensive care even if the parents requested. So what are some of the ethical principles which might be used to justify these guidelines? I've got two tables on the slides on the left that you can see. The bottom one shows you the survival and disability statistics that are used in the guideline. And the top table is one that I've borrowed actually from an Islamic bioethics model, where it's heavily used, but a very similar framework has been put forward in neonatal ethics literature by Dominic Wilkinson and others. And I think we use categories like these implicitly all the time as clinicians, but not in a formal framework necessarily. So first of all, the principle of beneficence or doing good. So it's obvious to us that clinicians should provide treatment when it's almost certain to be successful, which is that first category. And on the other hand, clinicians are not obliged to provide any or all possible interventions if they have a minimal chance of success, which is that fourth category. I'll come back to what benefit means in this context because it does involve value judgments, which will differ between people. And again, that these numbers are deliberately meant to be rough numbers that don't overlap because they are meant to be heuristics or guidelines that help you think about categories rather than being very black and white about specific percentages. So when a good outcome is uncertain or unlikely, which is that third category, then a trial of intensive care is seen as appropriate if parents request it after counselling. And then if complications occur which make a poor outcome more likely, then withdrawal of care would be recommended. I think that the use of the word trial is very important to use with parents and in our language because parents as well as us as clinicians worry about disability and suffering. So it's important to know that decision-making can change if prognosis changes significantly based on postnatal complications. And the zone of parental discretion in the Safer Care Victoria guideline sits within that third category, roughly, within the table. So we did, so after a few years of having the Safer Care Victoria guideline adapted and implemented within our hospital at the Royal Women's, we then did an audit of all of our antenatal counselling or consultations in the first 2 years after the change of guideline. So we had just over 50 counselling episodes per year prior to 25 weeks that we were requested to go and speak to parents who were at risk of having preterm birth prior to 25 weeks. So I thought it would be very useful to show you the results of that audit. So what we saw was that the decision making following counselling was quite different by weeks of gestation, as you can imagine. But to break it down for you, we had 6 consults that we did between 21+4 and 21+6. And 50% of them opted for intensive care from 22 weeks. So acknowledging that we would only provide it after 48 hours of steroids, and 22+0 being the cutoff. When we looked at the 20 consults in the 22nd week of gestation, there were 34 of those, and roughly 2/3 opted for comfort care in that 22nd week. There were 2 cases of, one was a termination of pregnancy, the other was induction with specific plan for palliative care in that 22nd week. And of those who opted for comfort care in the 22nd week, 12 of them opted for intensive care from 23 weeks, and 7 for intensive care from 24 weeks. In the 23rd week of gestation, it was very different. So you could see that almost 90% opted for intensive care. And actually, of the 3 that were for palliative care, one of them had severe growth restriction, less than 400 grams. And at 24 weeks, we only had 1 case in which the decision was made for comfort care or palliative care. And that was, again, of a growth restricted infant, less than 400 grams. So I think the key finding of this audit is that despite reducing our thresholds for resuscitation from 23 to 22 weeks, most families did request active care from 23 weeks onwards if we presented them with a recommendation for palliative care in the 22nd week, based on the Safer Care Victoria guideline and the prognosis of cases that it was based on. So moving on to thinking about another situation that we find ourselves in the NICU, and that's around withdrawal or withholding of intensive care in the context of brain injury, or for equally for infants with life-limiting conditions. To give you some examples of cases, we had a 41-year-old woman with early onset growth restriction for her fetus at 20 weeks. She then delivered by a cesarean section at 25+5, with the baby weighing 450 grams due to worsening umbilical Doppler flows. There was full antenatal steroid cover. There was a difficult intubation with multiple attempts following birth, with hypoxia in the first 15 minutes and relative bradycardia, which improved following the intubation and surfactant. Then subsequently, as is often the case, the first 24 hours were relatively uneventful. The baby was easy to ventilate with low pressures. However, the routine cranial ultrasound on the 2nd day of life showed bilateral grade 3 intraventricular hemorrhage and an extensive unilateral periventricular hemorrhagic infarct, which we would often call grade 4 IVH in the old system. So there was a discussion at that stage with the family, giving them the option to discontinue intensive care. And after 2 days of time, the family opted for extubation, and the baby was extubated in the mother's arms. This is a case of a baby with term HIE. The mother was 28 years old, presented to ED with a history of reduced fetal movements. The CTG was very concerning, with a sinusoidal trace. There was an immediate emergency cesarean section with evidence of placental abruption, a low heart rate, less than 60, and extensive resuscitation. The baby received cooling and had SARN at stage 3, encephalopathy. The baby was spontaneously breathing, but had an abnormal EEG. The early MRI subsequently showed extensive cortical and white matter injury. The discussion with parents were that there was a high risk of moderate to severe disability, and again, an option was presented for withdrawal of care. The family, however, opted to continue and were accepting of the disability risk. So by day 5 of life, the baby was rewarmed, was extubated, occasionally made very soft cries, but had a poor suck and no gag. The baby was requiring 4 to 6 hourly suction for secretions due to poor swallow. And ultimately, the baby was discharged home on full nasogastric feeds, and suction, with multidisciplinary follow-up, including the palliative care team's involvement. So we tend to see, three rough groups of scenarios based on prognosis in the context of HIE. The first is where the injury is very severe, and you could describe it as a total brain injury, where there's where the infant is unable to breathe, there's no voluntary movements or signs of conscious awareness. And in these cases, withdrawal of care is always recommended. It tends to always be recommended to parents. And it may even sometimes be situations where there may be an appropriateness to discuss things like organ donation, although that happens really rarely. Hospitals may go to court in theory to get permission to withdraw intensive care if the parents refuse. There are, several cases from the UK where this has occurred. Thankfully, it rarely occurs in Australia. The second group would be where there is a severe brain injury, but not total loss of brain function. So often these infants are breathing, they might make some noises, they may or may not have some feeding cues, so they are likely to survive but have little developmental progress. So in these cases, withdrawal of care tends to be recommended by the clinicians again. Some parents choose some parents agree with that, some parents will choose to continue, and the palliative care team are usually heavily involved in those cases to support the families in that journey, in particular to minimize suffering for the infants. The third group is where there is a brain injury, which is likely to cause moderate or severe disability, but it's not to that level of severity where we think there is variability in developmental outcomes with a prospect or a possibility of mild impairment. And that comes down to the issue of prognostic data, which is often limited. In these situations, withdrawal of care is often recommended. Many parents do go with that, but many choose to continue. And parents who continue often describe feeling judged if they choose active care. And interestingly, you can use a similar kind of grouping for other congenital or life-limiting conditions. So, in the first column might be something like a baby that has anencephaly. In the middle group, perhaps trisomy 13 or 18. And then in the third group, something like a congenital myopathy, where prognosis is more uncertain and there is a prospect of more mild impairments. So it's useful to think about these groups and when it might be appropriate to definitely go with the withdrawal of care, recommend it strongly, or provide it as an option with less of a strong recommendation. So how do we decide when withholding or withdrawing care is appropriate? There are really a broad range of approaches around the world. Everything from one end of the spectrum where quality of life and predicted suffering or present suffering is of such importance that withdrawal is permitted if you're expecting significant suffering. And places like the Netherlands, where they've even got guidelines for euthanasia in those cases. In the middle, there's the view that quality of life and suffering are important, but that there are other objective factors that should be considered also. And the right to life of the child, other obligations around the sanctity of life, other objective views that the parents might have about getting home, for example, and the importance of developing a relationship and with the broader family. The other end of the spectrum is that some people will say that and argue that quality of life should not be used to justify withdrawal of care, and that only futility or lack of benefits should be a justification, or in the case of an actively dying patient. So the majority view among Western bioethicists is that withholding or withdrawing are morally equivalent. However, you do have some arguing that withdrawal is more controversial than withholding. But there are even some views, particularly more recently, that withdrawal of care might actually be preferred over withholding because it actually allows you for more time to reduce uncertainty about prognosis or response to treatment. So you can be more sure about whether the withdrawal decision is correct. What we do know, though, about withdrawal of care from many empirical studies is that it is more psychologically difficult for clinicians and for parents. Dominic Wilkinson and Julian Savulescu back in 2019 spoke about the idea of an equivalence thesis, that and arguing that withdrawing and withholding of care are morally equivalent. But it is interesting that, even if they are, it's difficult to use that to resolve disagreements between physicians and families. So in that end, it's important for us to maintain that level of humility and seek to work with families and build consensus, even if we think that withholding or withdrawing is permissible in a particular situation, then it's about that negotiation process and potentially using time in your favor if the child is not being subjected to significant harm, and it's important to use that as a potential red line. So thinking about questions that have come up in the ethics literature as well around what we do with infants at those borderline gestations, I throw to you this question, which I find very interesting. So when we provide intensive care to a 22-weeker who eventually survives with a disability, have we created a disabled child, or have we brought a disabled child into this world? Or have we saved a child who survives with a disability? So this is actually a debate that happened relatively recently in the ethics literature, where some ethicists argue that we are creating disability when we intervene by resuscitating a 22 or a 23-weeker, for example. And implicitly, many of us as clinicians worry about this. But what it does when we do is that it creates a sense of moral responsibility when you think about it that way. And what it may lead to is more reluctance to provide care than for an older child with a similar prognosis. I would argue that regardless of the moral status of a 22-week fetus or infant, they don't become a person because we provide a treatment or not. So, similarly, an infant with a congenital heart disease that is dependent on cardiac surgery to survive, the cardiac surgery doesn't create the baby. And similarly, infants are dependent on milk to survive, but the milk doesn't create the child. So if we think about an argument from consistency or fairness, conditions with similar prognoses should be treated similarly unless there is an additional relevant moral factor. And that's a similar argument that people like Mark Mercurio, Annie Janvier, and others have spoken about. And I think the real question is whether there is sufficient chance of benefit from intensive care. So what are the benefits and harms of treatment? And is there a sufficient chance of survival without severe disability for this particular patient to justify us providing those painful and expensive interventions? Now, most of us will be familiar with the empirical studies over the last few decades that show that all of us, neonatologists, nurses, obstetricians, consistently overestimate the risk and severity of disability for preterm infants, and we're consistently more pessimistic about quality of life than parents and adult survivors of preterm birth. I'm not going to go into that literature, it's easy to find, but what I wanted to leave you with is a really interesting study from last year conducted by the Child Bright Group in Canada. So they asked a large number of stakeholders, including parents of extreme preterms, health professionals, teachers, adults born preterm, about whether they considered the particular scenarios to be a severe health condition or a severe impairment. So have a read of these three of the 11 examples or scenarios that they presented in the paper. And I'll give you guys 2 minutes to have a read and think about which of these, if any, you would consider to be a severe impairment or disability. And then I'll tell you about what they found in the study and how people responded. So I'll give you 2 minutes. yeah, feel free to pop in the chat if you want to give your answer. You don't have to. So I hope that's given you enough time to think a little bit about what you would classify those scenarios as. So these are examples from top to bottom of cerebral palsy, which is the first scenario, cognitive impairment in the middle, and language impairment at the bottom. And all of these meet the criteria for severe neurodevelopmental impairment as per particularly for scenario 2 and 3, it's because they fall below this 2 standard deviations, below the mean for the Bailey scores at 18 months. In particular, scenario 2 really surprised me. I wouldn't have thought it was, of all of them actually, that in particular that one, I definitely wouldn't have thought it was a severe impairment, but these scenarios are ones that have been carefully crafted by the authors who are follow-up experts in Canada. And they were all deliberately there to meet the criteria that we use for severe neurodevelopmental impairment in the research and follow-up trials that then inform the counselling that we give to parents. So these are the percentages of the 775 respondents who thought each scenario was a severe impairment. The infant with cognitive delay, which was scenario 2, which was designed to be more than 2 standard deviations below the mean for their Bailey 3 cognitive score, was considered to be a severe health condition by only 4.6%. It was only when there was cerebral palsy, which was scenario 1, or blindness, or when there was a combination of cerebral palsy and language delay, that the higher percentages of people said there was a severe impairment, as you can see there. So interestingly, there was actually little difference in the rankings or the evaluations of severity between parents, health professionals, adults born preterm, and the teachers when you presented these cases as scenarios or when you presented severe NDI as scenarios in this way. So of course, it's not to say that occasionally babies don't have outcomes more dramatic than this, and that there aren't babies with profoundly limited function. But I think this study is really important because we use the term severe neurodevelopmental impairment to make recommendations about life and death decisions and to prepare parents for the future. So we should be aware of the potential for miscommunication when we use the term severe, because what parents will consider severe will potentially take away as being severe, in the picture that they will have in their mind might be quite different from the reality of what the statistics are telling us is likely in that situation, or the range of outcomes that is likely. So I'll end there. I've got some take-home messages really summarizing from the thing, and then it'll be nice to open up to discussion. One of the points that came out is that in our change of guidelines with antenatal counselling, we saw that most patients most parents opted for intensive care from 23 weeks when antenatal counselling is given with a recommendation based on outcome estimates. We know that outcomes are still relatively poor at 22 weeks and are better at 23 weeks. However, we know that this will change as experience improves. And therefore, the way that we counsel and the recommendations we give will necessarily have to change. For any condition where chance of survival without significant disability is low, and again, stressing that the word significant is, we try and do a better job of explaining what that means for parents. Parents, as I mentioned, when the chance of survival without significant disability is low, parents are given the option of withholding or withdrawing intensive care. And we know that that involves value judgments. That doesn't mean it's the wrong thing to do, but it's important, therefore, to be consistent and fair in the way that we provide recommendations by doing that based on prognosis. There are different views on disability and acceptable quality of life that we should know about. However, it's important to prioritize avoiding suffering when the risk of death is high or when life is likely to be short. And I'll end there. There's some references that you can have a look at if we share the slides around. But thank you very much for listening.
Thanks, Amir. Look, again, I think this is a great overview showing us both, you started with the two examples, which are very, I think, familiar to almost everybody here. And what I really appreciate, you showed both sides, the good side where parents can make requests and the other end where we often are too negative in our perceptions and parents might have very different views. You gave us a lot of sort of examples and things and food for thought, including our classification. That was a new point to me, and I think that's really important, of what we call severe neurodevelopmental impairment, and these cases were an eye-opening to me. So this is a very good one. Look, it's we got lots of time, so please raise your hands, open your mic one at a time though, and your camera to start this discussion. Maybe while we're waiting, I have a question, which is, again, yes, we're resuscitating smaller ones, and you showed that as and that's probably a very good thing to do, and we should probably all do that in our local setting, looking back at our consultations. But if I had to guess, I would think that, say, in 24 weekers, about half of the parents would say, yeah, that's okay. Could be due to our counseling, the way we use words, but that will be very different than in your center. So now it's moved to 25 was really loud. We should do resuscitation, move to 24. And apparently your setting is not a significant problem, but in other settings, what do you think, how people will respond to that, or clinicians predominantly?
Yeah, it's a good question. And I think, the lines have shifted slowly over the decades, haven't they? So it's something where the ethical issues don't change. It's just where, which group of patients we're discussing them in. So I think nothing has changed from an ethical point of view, but certainly as prognosis changes, it really then leads to those situations, like you said, where at what point does the outcomes for an infant become high enough that we feel uncomfortable about providing parents the option of palliative care or not providing intensive care. So again, that's a value judgment, but at we have to draw the line somewhere, and having some framework or some consistency in how we do so is really important, and so that we can have similar decisions for different babies, potentially even applying it across to outside of the preterm context, a baby with CDH or an infant with a chromosomal abnormality, where thinking about the prognosis might help us to say that is the chance of the baby doing well long-term high enough that we should not even have that discussion about palliative care? Should we give parents the option, parallel planning? Should we not even provide the option because we think the outcomes are so poor? So I haven't really answered your question about the 24 weekers, but I think we've had a small number of cases where parents will feel that the risk of disability is too high and it's unpalatable to them, but it's actually really uncommon. And I think that goes to the point of how we counsel and the recommendations we make, that most people will go with that and will take them at face value. So we've got a lot of responsibility, and in those really small number of cases where parents push back, then that's why these are guidelines. We take into account other factors. Are there any other risk factors that make the prognosis slightly worse? What's the family situation? Is there a wiggle room to respect the parents' wishes, or do we really feel like the outcomes are so good that we should put our foot down and say that no, we will still provide intensive care? So we don't have a very hard rule, but I think importantly, we have these discussions at a group level. So the whole consultant group will come together when we've got these really challenging ones, at the borderline of what we think is appropriate or outside of it, and try and make a consensus decision.
How is that balance out against abortion? You know, ethically, because that could be a completely healthy child. It's just an interesting concept which I'm just thinking about, like if this is all too much burden for whatever reason, which might be very different than our views, is that ethically different or?
Yeah, it's a good question. I mean, it's certainly that issue is there's a reason. Some people think that there is a difference, and which is why you do tend to get some people argue that the lines get very uncomfortable when the lines between abortion and resus and viability start to cross each other. People get very uncomfortable, but actually, there's a range of views. Some people will say that there isn't a morally difference. There isn't a moral difference between the fetus before and after it's born, and actually, even though legally lines are drawn when the baby is born and has its first breath, that affects the responsibility of which clinician has to deal with it, but it doesn't really necessarily change the moral status of whether it's what is the ethically appropriate thing to do. So I think there's a range of views, but certainly I think the arbitrary line of being a fetus or an infant is not morally relevant. So if you think, the responsibilities shouldn't be based on that, even though legally they are. Yeah.
So there's some questions. Thomas had a question about counseling, and like you mentioned, it's a big responsibility. How often do we retrain, and update? How do you do it in your center?
That's a great point, and I think it's something that we are getting better at. We need to have better processes for it, but one of the things that has really helped has been discussions at a group level and consensus decision making. So the Safer Care Victoria guideline prompted a lot of that discussion in order to then implement locally. So that was a very, very useful way to try and get consensus about where we put our red lines, what situations we will all be comfortable with, so that we've got consistency across the board, and one set of parents will not get a different outcome if they're meeting one clinician versus another, because that remains a problem to some extent across hospitals, despite the fact that it really shouldn't. So certainly for us, we have really benefited from discussing all the borderline cases at a group level and trying to come to consensus decisions, as well as having guidelines to give us the cases that are clearly within the zone of parental discretion that we can feel comfortable making our decisions with, and then learning from each other about how we make decisions in those borderlines of those zones. But you're right. I think the way that we use language is not necessarily, we're not training well for that, and we don't have formalized processes in place for how we improve the language that we use and address the implicit way the bias enters into our language, either positively or negatively. So we should have better systems in place to retrain and for the actual process of counselling rather than just the decisions.
Yeah. And part of that decisions in the Victoria guideline includes factors such as estimate of gestational age, estimate of weight. I guess two questions here. One from Charles: how do you factor in measurement variation? Maybe not error, but measurement variation, which is invariably there. And the second question would be, to me, like, is that being used, for or against? Like, is there a sliding slope happening? That's small enough or big enough, or how does that work?
Yeah, that's a great point. And we've had, many cases or several cases recently where, the infant who's 22 weeks or 21 plus 6, then they're wanting us to have the discussion. However, the baby is growth restricted, and you're getting estimates based on the scans of 350 grams perhaps, plus or minus 40, 50 grams. Because there's a lot of error there, if we're saying it's plus or minus 10% or more, then you are really a little bit in the dark as to whether this falls within a prognosis that's acceptable. And we're using the rough cutoff of 10% as an acceptable prognosis in order to go within the zone of parental discretion. And that's to kind of use a consistent number that we use for a 22-weeker who has not been adequately steroid prepared or is an outborn, has a less than 10% chance of survival despite intensive care, based on the numbers that the guideline, Safer Care Victoria guideline, used. So from a consistency point of view, we try and think about it roughly like that. Is in this case, with the growth restriction and the gestation of the infant, is it clearly a case in which the prognosis is much less than 10%, in which case we wouldn't be offering intensive care? Is it, borderline, or is it in that kind of 10 to 50% category where we would feel it is within the zone of parental discretion? But I agree with Charles, the measurement error in ultrasound creates a lot of stress, and we have to have some arbitrary lines. I think it's impossible to avoid that, so that we are then not allowing ourselves to slip into a situation where we're providing intensive care for cases with, very, very borderline or very, very low chance of success because we feel pushed by the parents' requests. So it is that balance, and as much as we have to be nuanced around the borders of the zone of parental discretion, we have to have some red lines to help us give our recommendations, and I think at the same time appreciate that there may be specific situations where we might want to break that in very, very limited circumstances, because this might be the final chance for the parents. There might be, circumstances for them specifically, or for that infant, where we may want to support their decision, where even though we would not do it for 9 times out of 10.
So summarizing, the measurement is the measurement. That's it, kind of thing. That's what we're going to go with. But there are specific scenarios where conversations might lead that still the measurement is the measurement, but you might accept a different zone. That's, that makes it's human, isn't it? It makes a lot of sense.
Yeah, and I'm interested to see if anyone's got any other, ideas about, or how they've done things in those situations. Often we've said that, look, if the ultrasounds do not have 400 grams within their error margin, then that's too small for us, and we've just chosen that arbitrary number somewhat, but it is based on very, very small numbers, knowing that the under 400 grammers in our unit have done very badly and have had a significantly less than 10% chance of survival.
You already mentioned the peripheral centers. Do you get like phone calls from the peripheral centers, or they're just born there and they ask what to do? How's that go?
Yeah, I'd defer, I guess, to the Piper colleagues here in the audience who might want to speak up, but certainly the idea of having the guideline at the Victorian level rather than just at a hospital level was to create that consistency for women who are presenting with threatened preterm birth. So the idea is that there is more consistency in terms of the transfer, for example. So if there is that risk at 22 weeks, that they are at least transferred to have further discussions around provision or not of intensive care, rather than a commitment to active or palliative care. But there's that acknowledgement in the guideline, first of all, that those discussions are best placed at experienced centres who deal with it, to be able to have that nuance. But there are thoughts and discussions at the Piper level in Victoria about other ways of potentially doing it, using technology to take the experienced counsellor to the mother rather than the mother to the counsellor, to maybe have some of those conversations that may avoid transfer if there is a clear decision made for palliative care. So there's a lot of room to do things better, perhaps, but at the moment it's very much to optimize things. And that includes the way the counselling is done, by having them in a tertiary centre.
Maybe a shift to the other side, as a large topic of discussion, is towards the let's just take the example of HIE and their outcomes, and particularly their range of outcomes. It can be just, yes, we have a point estimate of what it is, but the range of outcome is so variable. And then there is, of course, your personal values and ideas. And you mentioned that particularly the parents who said, no, I want to continue, they felt, I don't know, uncomfortable, or can you explain a little bit more about that?
Yeah, there is some empirical literature to say that there is that negative perception sometimes that often comes across for people who do want to continue. But it is certainly, there's a diversity of moral views, but it shows how difficult things can be, not when prognosis is thought to be poor and people are requesting treatments that we think have a low chance of benefit, but actually when the prognosis is very broad. That's, I think, a lot harder. And in those situations, again, coming back to justice and consistency, it's important to think about, what does society think is acceptable for other situations with similar prognosis? If we have a really uncertain case, do we, err on the side of pushing for palliation, or do we err on the side of time to make prognosis, slightly more, or slightly less uncertain, or default to prioritizing parent wishes? And that seems to be the main push at the moment with shared decision making, that we, especially the Australian context, we're less likely to go to courts and make a best interest argument that the baby's suffering and we want to stop despite the parents' views. The general culture is, in our healthcare setting in Australia, has been that there is a bit more deference to parents, and more deference to give time to help clarify somewhat. There should definitely be limits to that, and where we draw the lines again should, as much as possible, be based on whether we think that we are causing significant burden and harm from the interventions we're providing.
All right. Any questions or hands up from the audience? We've been chatting now. Any other comments or things people want to discuss or bring up for Amir? Like, too shy. Well, look, it is not an easy topic to talk about, which I always feel. We think about it for sure. Putting it into words, as you said, it can be very challenging, and not only amongst colleagues, even putting it into words, because we all place our words based on our own, I don't know, history, how we grown up, how we were raised, our religion, or whatever other factors determines the persons which we are today. Look, Amir, this was a great overview. Thank you so much for presenting for us. Thanks everybody for attending and being here. I think next week we have Deborah Harris talking about gentle treatment of hypoglycemia. Am I right, Julie? Just nod or tick yes if that's the case. Thanks for attending, and I hope to see you all at the next session. Thanks, Amir. Thank you.